So stents are basically a metal scaffolding, and current generation stents are made of special alloys. So one group we have a platinum chromium, the other group we have a cobalt chromium. So these are the metal platforms, and on which there is special drugs which are coated, either everolimus or a zotolimus or a biolimus drugs. These are the drugs coated on the stents. So basically, these drugs prevent excessive growth of tissues within the stent. Now, how the stent work is essentially when you have a narrowing in an artery, so you stretch the narrowing with the balloon, and there's always a chance it will collapse again. And to prevent that, we provide a scaffold. Like when you're building a house, you have the scaffold, and essentially what it does is it stops the artery going back to its original or narrowed state. That's how the stent works. And after a while, what will happen is your own tissue grows inside the stent, and then the stent will become part of your body. So it's mainly a scaffold which it provides. And the drug on the stent will stop excessive growth of tissue within the stent.
I'm curious to know what happens to stents after the treatment, actually.
So what will happen is once you deploy the stent, over the next few days, your body will start coating the stents with its own cell called endothelium. So once it covers, then your stent will become part of your body. So once stent goes in, you cannot take it out. It becomes part of your body, and your body won't react to that stent anymore, especially when it's covered with a coating.
And are there any proven alternatives available for stents at the moment, or is that the only option available?
No, it's a good point you asked me, because we are increasingly using what we call a drug-coated balloon, which are essentially a balloon which have been coated with similar drugs that goes on stents. The idea behind is, for example, stents are great, but as you put long layer of stent, like in terms of length, or if you're putting stents in a small arteries, it increases the risk of what we call restenosis, or the stents which narrow within the stent, narrowing can develop. Once it develops, it's very difficult to treat, because once the stent starts narrowing, no matter what you do, the recurrence rate of restenosis is high. It's over 15%. So we want to avoid stents in certain lesion. As I said, it's a long lesion, small vessel, or if you want to treat patients who can't take blood thinner. So, for example, once you have a stent treatment, you have to be on a blood thinners, aspirin and clopidogrel, for at least 6 months or maybe even a year. Whereas with these drug-coated balloons, because there is no metal, there is no polymer, all we have a drug which goes away within a month in the body. The patients can only take aspirin and clopidogrel for a month, after which you can stop one of the antiplatelet therapy. So patients who can't take antiplatelet therapy, for example, if they have any bleeding problems, or if they're waiting for an urgent surgery like cancer surgery, we are using drug-coated balloon. Now, drug-coated balloons have been around for almost more than 10 years now, but they've been increasingly used now, and we are one of the leading centers in the UK to adopt this technology. So in my practice, I use probably around 25 to 30% of the cases with or treat the patients with drug-coated balloon, because I do feel that they have an excellent role in places where you want to avoid using stents.
That's great to hear that at your center you use an alternative like drug-coated balloons quite extensively. But I guess it's not for everyone, isn't it? It's very subjective, and not everyone qualifies for it.
Yeah, I mean, as I said, not everyone qualifies for a drug-coated balloon, and I don't think so drug-coated balloon will ever replace stents completely. But I'm sure, from my experience so far, it does carry some indications. I would say 25 to 30% of cases can be treated with drug-coated balloon, and in fact, it avoids long-term complications like stent thrombosis or restenosis with a drug-coated balloon. And in fact, a point to make that one of the drug-coated balloons in the market is from India. It's produced in Surat, and it's one of the biggest companies now producing a special balloon called sirolimus coated balloon. Look, my interest is interventional cardiology, but again, interventional cardiology has got a lot of subspecialties. So my main interest is opening this chronically occluded arteries or arteries which have been blocked for a long time, and it needs a special skill set and training which have been received from one of my mentors from Japan. So we are now researching on a blocked artery within a previously placed stent. It's called intra-stent occlusion. So we have a biggest database of it, and we are currently in the process of writing a paper on it to see what are the long-term outcomes of these blocked stents, and also what are the best treatment strategies, whether to go for another stent or just a balloon or a special drug-coated balloons. And my other area of interest is drug-coated balloon technology, which have been extensively involved since 2012. So we are using these drug-coated balloons in small vessels and patients who can't take blood thinners for an extended period of time. And we are researching on a special balloon which has sirolimus. Most of the drug-coated balloons available in the market have paclitaxel drug on it, which is a special kind of drug. The only problem with the paclitaxel is it's a toxic drug, and it's a very narrow therapeutic window. And there are some reports in the peripheral intervention that there may be an increased risk of mortality in patients who have received these special balloons. So the new technology is on sirolimus coated, which is a drug which is less toxic and in fact more used on stents. So we are working on this technology. We have a lot of patients treated with this. We have got ongoing follow-up. We are in the process of publishing a paper which is almost accepted in a journal. That's my second interest. And my last interest is a shockwave, which is currently one of the, we could call a big leap in coronary intervention of treating intracoronary calcium in a safe way as compared to what we were doing in the past. And there are several studies which has come out, and we have now a sort of registry data from our center with lots of other centers in the UK and Europe. So that's where my interests are.
These technologies that you just mentioned, what kind of timelines are we looking at? I think some of them are already in use, or some of them would become available. Can you tell a little bit more about that?
No, look, shockwave is already available clinically. So it's used in a lot of centers in the UK. In fact, in our hospital, we have used in almost 80, 90 patients. In other parts of the world, it is coming. So, for example, in India, they only recently used in the live conference which I went in Delhi. So it's already available. The shockwave is already available. But what we don't know is what is the long-term data, how does it behave, how efficient it is. So which is what all the papers will come out. So our data, for example, is a real-world data on patients we have treated. And we have excellent data or outcome of it, so that we have a very good safety margin and very good outcome so far. But we need more papers and more results, like the way bioabsorbable scaffolds. They came out very nicely. On a few years later, we realized that it's not as good as stents. So only the long-term data will say. It's been around for so many years now. The paclitaxel balloons are always used in every centers. But the sirolimus coated balloon is a relatively novel technology, which some centers have embarked. A few centers in the UK, we are one of the biggest centers, which we are doing some research on it, comparing with the paclitaxel's balloons. That is also available. They're CE marked. And so once you get CE marked, you can use in Europe. And that's what we have been using. So yes, that's probably, and the CTOs, as I said, it's escalating globally. So all these are available for clinical use.